Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуально в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників і ми займаємось такою складною патологією, як увеїти. Це орфанні захворювання, які є однією з основних причин сліпоти у молодих людей, у дітей, яку неможливо вилікувати хірургічно.
Сьогодні інститут надає як консультативну, діагностичну і лікувальну допомогу нашим пацієнтам. Ми лікуємо абсолютно всі, без виключень, офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
У нормі судинний гомеостаз і стабільність судин підтримуються завдяки вищому рівню ангіопоетину-1 порівняно з рівнем ангіопоетину-2, що призводить до активації рецепторів ендотелій специфічної тирозинкінази 2. Це забезпечує цілісність ендотеліальних клітин і запобігає трансудації або судинному витоку. Перицити вистилають кровоносні судини та сприяють їх стабільності. А лейкоцити вільно переміщуються по кровотоку. При патологічних станах запускаються механізми ангіогенезу, що призводить до зростання рівнів ангіопоетину-2 і фактора росту ендотелію судин А, і це сприяє розвитку захворювання. За такого сценарію, через підвищення рівнів ангіопоетину-2, він починає конкурувати з ангіопоетином-1 за зв'язування з рецепторами ендотелій специфічної тирозинкінази 2. Це призводить до нестабільності судин і посилення впливу фактора росту ендотелію судин А. Судинну нестабільність можна охарактеризувати наявністю трьох ключових факторів. По-перше, це трансудація або судинний витік, викликана порушенням цілісності ендотеліальних клітин. По-друге, це наявність запалення. З'являється адгезія лейкоцитів до стінок судин. Вони переміщуються у позаклітинний матрикс і вивільняють прозапальні та проангіогенні цитокіни. По-третє, відбувається утворення нових судин у тканинах – неоваскуляризація. Випадіння з процесу перицитів сприяє подальшому зниженню стабільності і початку ангіогенезу. При цьому ангіопоетин-2 посилює ефекти, спричинені фактором росту ендотелію судин А, що сприяє утворенню нових судин і подальшій трансудації або судинному витоку. Спільна дія цих факторів сприяє виникненню нестабільності судин, яка спостерігається при захворюваннях судинної оболонки ока і сітківки ока. Підхід до лікування став іншим. Настав Час інновацій. Вабісмо – це перша затверджена біспецифічна молекула для унікального пригнічення VEGF-A та ангіопоетину-2 для відновлення стабільності судин. Завдяки модифікованому фрагменту, що кристалізується, зменшується системний вплив і потенційна здатність спричиняти запалення. Відкрийте нові можливості одночасного пригнічення двох сигнальних шляхів. Вабісмо, де зустрічаються два світи. Вабісмо рекомендований для лікування дорослих пацієнтів з неоваскулярною ексудативною віковою макулярною дегенерацією та порушеннями зору внаслідок діабетичного макулярного набряку. Зі світу, де терапія спрямована лише на один сигнальний шлях, пориньмо туди, де вже панує інший підхід до лікування. Запропонуйте вашим пацієнтам нові перспективи, поєднуючи два світи через одночасне пригнічення двох сигнальних шляхів. Спрямуйте терапевтичні зусилля одночасно на VEGF-A і ангіопоетин-2. Вабісмо, де зустрічаються два світи. Вабісмо рекомендований для лікування дорослих пацієнтів з неоваскулярною ексудативною віковою макулярною дегенерацією та порушеннями зору внаслідок діабетичного макулярного набряку. У нормі судинний гомеостаз і стабільність судин підтримуються завдяки вищому рівню ангіопоетину-1 порівняно з рівнем ангіопоетину-2, що призводить до активації рецепторів ендотелій-специфічної тирозинкінази 2. Це забезпечує цілісність ендотеліальних клітин і запобігає трансудації або судинному витоку. Перицити вистилають кровоносні судини та сприяють їх стабільності. А лейкоцити вільно переміщуються по кровотоку. При патологічних станах запускаються механізми ангіогенезу, що призводить до зростання рівнів ангіопоетину-2 і фактора росту ендотелію судин А, і це сприяє розвитку захворювання. За такого сценарію, через підвищення рівнів ангіопоетину-2, він починає конкурувати з ангіопоетином-1 за зв'язування з рецепторами ендотелій специфічної тирозинкінази 2. Це призводить до нестабільності. Спрямуйте терапевтичні зусилля одночасно на VEGF-A і ангіопоетин-2. Вабісмо, де зустрічаються два світи. Вабісмо рекомендований для лікування дорослих пацієнтів з неоваскулярною ексудативною віковою макулярною дегенерацією та порушеннями зору внаслідок діабетичного макулярного набряку. Зі світу, де терапія спрямована лише на один сигнальний шлях, пориньмо туди, де вже панує інший підхід до лікування. Запропонуйте вашим пацієнтам нові перспективи, поєднуючи два світи через одночасне пригнічення двох сигнальних шляхів. Спрямуйте терапевтичні зусилля одночасно на VEGF-A і ангіопоетин-2. Вабісмо, де зустрічаються два світи. Вабісмо рекомендований для лікування дорослих пацієнтів з неоваскулярною ексудативною віковою макулярною дегенерацією та порушеннями зору внаслідок діабетичного макулярного набряку.
Let us start our session of satellite meeting of Roche company. How to improve vision with faricimab preparation. We are going to have 4 reports. Korol Andriy Rostislavovich is going to open the section with anti-angiogen therapy with NVDM. Dear colleagues, some time we'll spend observing this classification of age-related macular degeneration, because this disease is brighter and more voluminous, and there is dry form, there is exudative form with the different types of neovascularization with intermediate stages. There are other classifications available. Some of them are more simplified, oriented at localization directly, focusing directly on neovascularization. This classification has been changing, and the neovascularization has several types. Like first type are hidden vessels. Classic neovascularization is under neuroepithelium, and the third type is retinal hematose proliferation or retinal choroidite anastomosis, and polypoid choroidal vasculopathy, which used to be considered as polyps, but we understand that these are newly formed vessels. In different types, we pay attention to presence of detachment of pigmental epithelium. These are clinical cases of different variations of neovascularization. Of course, in any type of subretinal neovascularization, we require preparations that are anti-VEGF. For many years, I can say maybe many decades, the use of this kind of therapy, we speak not only about effectiveness, but also about comfort, about the needs of our patients, which can be satisfied by us. This is the frequency of injections. We are trying to limit the number of times when a patient has to visit our clinics. This is the complication for a patient's relatives who sometimes have to follow, have to care about their relatives, our patients. We are looking for the ways to prolong the intervals between the administration of these preparations and keeping high effectiveness. This is not only impacted by FRES factors type A, but other growth factors recently found passage, for example, associated with angioexin 2 and receptors of second type. We know that angiopoietin 1, this passage is required. It is in order to provide for the healthy vessels, and if it is damaged, it leads to instability. Common FRES factors are needed for functioning of common vessels in the normal condition, even in development of fetus. In other situations, these FRES factors are damaging and we have to suppress them. Besides, due to some researchers, it was found that in angiopoietin 2 level, the homeostasis of vessels increases. This is in age-related macula and in thrombosis of retina and in diabetic retinopathy and in all the enlisted conditions. Fortunately, pretty often new moleculars are formed. Why fortunately? Because I think that the more molecules, the more possible it is to find more individual method for treatment of certain patient, to find an antibody for VEGF-A and anti-angiopathin 2 to block the pathological factors which cause neovascularization development. We have long-term results of TENAIA and Lucerne. These are the research organized in order to compare aflibercept and faricimab effectiveness. As a result, it was found that faricimab with interval of 12 weeks had 80% effectiveness in this long-term study. Another positive information for us was that we found that according to the data of this research, during load injection, faricimab in the best way decreases the thickness of the retina, decreasing the edema in macula. The biomarkers in OCT, biomarkers of neovascular process in age-related macular dystrophy. So these biomarkers is presence of retinal liquid, subretinal liquid, detachments of retina and fibrovascular detachment of pigment epithelium of retina. We know that this can be caused this can cause the tear of pigment epithelium level. This happens in neovascular detachment, which can lead to acute worsening of patient's condition. You can see pictures of an example from our clinical practice with a really large tear detachment. The problem of detachment of pigment epithelium in patients with non-vascular age-related macular degeneration is seen in 30–80% patients, according to data of different research. The liquid under the detached pigment epithelium is more stable than intraretinal or subretinal liquid. This kind of detachment requires more long-lasting anti-VEGF therapy. As regards the data of TENAI Lucerna research, the patients were compared according to localization in the center of fovea and thickness of pigment epithelium was balanced in all groups studied. More than 80% of detachment in the beginning of study was fibrovascular, meaning that newly formed vessels were underneath the detachment. According to the research, faricimab was more effective as compared to aflibercept, and at the same load, and fewer patients had cirrhosis detachment in case of faricimab as compared to aflibercept. Faricimab was tolerated well until the end of the research. On our previous satellite, Mykola Mikhailovich showed the result of that study. So in case of aflibercept, it was 1.5% of detachments. We know that they occur in our practice, and we are actively trying to find the ways how to avoid that. And we know how to counteract and to diminish the effect of such tears. Thus, I can say that with help of faricimab, the results of treatment of pigment retinal detachment at the load stage were more effective than aflibercept in the same load and in the same period and at the same frequency of injections. Thus, we know that according to literature, according to scientific papers, faricimab demonstrates early effectiveness in improvement of architecture of pigmental epithelium in patients with macular degeneration, which tells us that faricimab is an effective method of treatment of this condition. In other publication, we find that faricimab diminishes the volume, the number of cases of pigment epithelium detachment in primary patients who had not undergone any treatment before the referral, as well as in secondary patients which had had no response to prior therapy. So faricimab is both nice choice for first therapy and for continual for the follow-up therapy. After these data of clinical research, we are going to switch to our data of our clinical cases. We know that according to instruction, faricimab is used with the increased number of loaded injections, 1 per 4 weeks, so 4 times administration, after which we follow up the patient, and the following administration is possible after 16 weeks. But if we see the progress of the disease, then we can perform the following administrations earlier. Here is our clinical case number 1. This patient had been treated by us for half a year. He obtained faricimab. Like they say, this patient was naive. This is the patient who had not undergone prior anti-VEGF therapy, so we consider him to be primary patient with a really nice anatomic response, really effective response to administration of the preparation, with increase of visual acuity. As you may see on the slide, the interval was 17 weeks. According to the instruction, the patient came to us after the 3rd dose, not after the 4th. In our country, it is actually possible. And after additional administration, we observed this patient 17 weeks afterwards, because he did not have opportunity to visit us earlier. We wanted to make sure that we did not miss any dynamics. So in the end of April, a month ago, he came to us with these results. Another patient with age-related macular dystrophy was followed up by us for 3 years before he had been treated by aflibercept, and with a pretty nice result. The interval was 8 weeks with a good response. So in total, he got 18 doses with the 8 weeks interval, like I said, and after 9 weeks, after the 12th dose, it happens so that after we increase the interval for 2 more weeks, there was a relapse. We offered the patient to use faricimab. The patient agreed, so we performed several injections. This patient came to us in March of this year, and the effect of this following faricimab treatment brought improvements. this patient is still treated by us, advised by us. Another patient with fibrovascular detachment of pigment epithelium. I cannot say in this case that this woman was naive, but she was indeed primary. Like we cannot say that we were there first ones. So we offered her treatment, but she was thinking it over, and during this period of the consideration, her condition worsened and her visual acuity decreased. We used loud doses. As you may see, the patient was in the beginning of April. She visited us. We obtained positive dynamics, decrease of detachment, and improvement of visual acuity. And we are continuing her treatment now as indicated as per the instruction. And another patient, a really exciting case, primary patient with detachment of pigment epithelium. The load dose of the preparation gradually 5 weeks after the fourth injection. We are expecting her for the fifth time for control examination. To conclude, I have to say that faricimab is an effective preparation to treat neovascular age-related macular degeneration due to its mechanism of double action. It at the same time controls the growth factor of endothelium of VEGF-A vessels, which allows to impact the key factors of development of the disease. The results of the research show that faricimab demonstrates improvement of morphological parameters, decrease of height of detachment in particular, as well as successful safety profile. So faricimab is a prospective preparation for treatment of patients with this condition, even those who had not undergone anti-VEGF therapy before. Thank you for your attention.
Коротеньке запитання. Що якщо сталося наступне?
Sorry, short questions.
Розташування пігментного епітелію без
Spheros of
пігментного
epithelium
епітелію
detachment,
Що
and
робити? Неосклеризації немає. Колонія,
there
не
was
колонія,
a
якщо колонія,
tear
то
of epithelium without revascularization. Should we inject or no? You know, in such a condition, if there is a tear without injection,
цю ситуацію, то там такі були утворені
I
судини, тому що
consider new formated
якщо воно дійсно існує без
vessels
судин.
to be present there, because we may have layer detachment without these serous vessels, but we know that this is the stage of development from dry to wet form. So I proposed it to consider as a profilative form and to conduct necessary therapy. The next report Umanits Mikola.
Успіх у лікуванні діабетично-макулярного набряку.
Successes in the treatment of diabetic macular edema.
Шановні колеги,
and some decision solutions from theory to practice. So let's continue our interesting topics for discussion. Of course, the relevance of diabetes mellitus and its consequences is very high. Some figures I have already mentioned. By 2021, new cases of new diabetes mellitus cases, the same figure in 2023, unestablished diagnosis increase also every year. Of course, it's a very relevant and acute cases, and in 8 from 10 cases, there is a decompensated period of this disease. Of course, the cooperation of endocrinologists and ophthalmologists is a key issue. First is endocrinologist consultation, and then we need the cooperation with ophthalmologists. Fortunately, we have guidelines we have information in all into protocols. So protocols of diabetes mellitus, first type and the second type. Of course, when we have diabetes, diabetical retinopathy, then edema, it is one of the widespread reasons for decrease in vision, and it causes 80% in patients with a proliferative stage. Classification of disease proven in 2010 on the meeting of association. There were grouped four types of edema: subclinical, focal, diffuse, and complicated. Diffuse and complicated were distributed to ischemic and non-ischemic types. Subclinical edema is a new term. It was introduced by Naumanko. It is subclinical because we are not able to give prognosis. Maybe OCT results are good, but we have fovea central coffees indices. The ratio of retina and fovea thickness, and if it is more than 0.8, there are initial changes of retina. At that time, selective laser coagulation was proposed, maybe a special regimen of following up for such category of patients. So this classificational unit is very useful. Then focal, we know it. It's the signs of focal edema. There are no peculiarities. When we have focal edema, we can treat focal edema, and we have here a lot of options. Visual acuity is very high in such patients. Diffuse edema can be of ischemic and non-ischemic type. If we are talking about non-ischemic, you see the classical image. Non-ischemic, there are signs of bad perfusions of choroides. Then complicated edema of macula can be also ischemic and non-ischemic. Is characterized by signs of diffuse edema, rupture, pre-rupture, occlusion of central vein or its branches. Combinations of these clinical factors. What about modern international classification? It is simple. In order to understand our further actions, it was recommended by International Council of Ophthalmology, and there are no in 90% there are no signs of diabetic edema, so everything is okay, and we should follow up this patient. Then diabetic macular edema with a central involvement of central parts. We should start anti-VEGF therapy on that stage. For today, all modern and state clinics are equipped with special devices to perform diagnostics, because fundus cameras for fixations and photos of fundus, OCT, fluorescent are presented everywhere. Angiography, unfortunately, is not presented in every clinic. Photo registration is really very useful. We can see the dynamics, follow the dynamics. There was a study RDTS, and this classification was used. It is too complicated, there is no clinical orientation, and it can be used only for clinical randomized studies or for screening of patients with diabetic resistance. But we have to with this methodology, we can follow up the dynamics. Fluorescent angiogram helps us to examine the circulation, the presence of ischemic zones, signs of neovascularization. Then Irving gas atrophy syndrome and diabetic macular edema, whether we have exudation or no. Angiogram, of course, help us to review this. It is necessary to do this procedure very quickly, and you have to be very experienced to perform this procedure, because there can be side effects on behalf of patients, and we have some problems with registration. It's invasive methodology, and of course the staff should be experienced. What about OCT? It helps us to examine, to assess the thickness of retina, and of course it was a great achievement in diagnostics, and it helped us to establish diagnosis of a lot of diseases together with diabetic edema. Another one quantitative step was this tomography. Of course, we have no opportunity to assess the blood circulation, but it helps to assess the eye in general. These are all CT markers to assess the condition of retina, vitreoretinal macular phase, presence or absence of foils, localization of liquid, of leakages, intraretinal intraretinal leakages, infiltrations, maybe damages of external membranes. So it helps us to assess a lot of parameters. Angio CT I have mentioned. What can we tell? There are a lot of medications for today that can inhibit two independent ways of neoangiogenesis. We inhibit a factor of growing of endothelial vasculars and angiopoietin 2. We can control neovascularization and leakage, inflammation process, and fibrocell proliferation on the surface of retina using faricimab. So we inhibit VGF and anti-BF2. What about biomarkers and their behavior when we use Vabismo? Hyperreflective spaces, foci. We are talking about hyperreflective focus or focals, and it's new information for me, and this identification has appeared 5 or 6 years ago. These are hyperreflective small foci, and their reflective is practically the same as the layer of nervous fibers. They are included in the thickness of retina, and they are situated in the inner sides of retina, and they can be also in choroidea. And then micronephrisms are also well-known biomarkers for us. These foci, they are small, present all over the retina. In patients with diabetes and age-related macular diseases, their amount decreased by administration of steroid medication. One of the origin hypothesis is the presence of inflammation cells. If we influence on angiopoietin 2, we influence on foci, and we decrease bad prognosis for our patients. What can we do with this foci? If we make Vabismo injection, you can see patient group indicated by a gray color. They were administered aflibercept once in 2 months, and green color tricobastamp. You can see that foci decreased in every group, but in a large amount, faricimab was more effective, both in external and internal layers. So inhibition of those elements together with faricimab therapy is much better. What about the escudates? These are white yellowish spots associated with micronephrism. Hematoretinal barrier is impaired, and we can see them both on OCT and usual photo. What about faricimab compared to aflibercept therapy? You can see that every anti-VEGF medication decreased the amount in 1 and in 2 years, but during the second year, the result of faricimab is a little bit better, not dependent on the regimen of administration. Microaneurysm. The study was the next calculation the number of microaneurysms before administration of faricimab, and then began to administer faricimab in loading doses. And there was a control group that didn't get anything. The second group has a worsening in their conditions, and first group has an improvement by 60%. So there was a decrease in microaneurysm amount by 60% in first group. Of course, we have leakage together with the microaneurysm. Having calculated the area of microaneurysm together with aflibercept and faricimab administration, the leakage area was twice less in infliximab compared to aflibercept group. If there is no leakage, and so there was a leakage regress and visual acuity was increasing. The next category, next biomarker, epithelial retinal membranes. As far as you remember, ANG2 stimulates its growing, and if we have anti-VEGF medication in 1 year after anti-VEGF usage, will have antimacular proliferation. Infliximab and aflibercept, the frequency of happy molecular proliferation was reduced in infliximab group. Infliximab regimen was described by Andrei Nikolaevich. If we are talking about diabetes, there are 4 loading doses, 4 millimeters each dose, and depending on our result, we can prolong the interval between injections. We prolong for 1 month, and if the process is without complications, we can administer 3 doses a year. We have a lot of such patients. If there are some complications, we can reduce the term of administration. Diabetic retinopathy, proliferative neovascular form, a macular edema, infliximab has a very quick effect, especially if we are talking about liquid. There are no intraretinal cysts. Of course, we have edema, but the retina thickness decreased. The next example. Also, we have a complicated macular edema. The same example. What should we do when we have such an edema? So vitrectomy is recommended. Unfortunately, the forecast is not good and effective without this surgery. There will be a recurrence of edema, and we will have to perform a surgery. It was our strategy. The first thickness of retina was 704 microns. You can see that fundus is quite good, no proliferative membranes, detachment. The main goal is to remove epimacular fold and internal membrane and tamponade of intravitreal cavity. We can also use air if there is no hemorrhagic process. There is a process of ELM removal because patients with diabetes adhesion of ILM is quite significant, and it is much more difficult to remove this membrane. Coloring, several words about coloring, because you see the external foil. Data just after the operation. So vitrectomy helps us to decrease by 120 microns. And then administration of anti-VEGF medication. So we have double effect. We remove vitreous body as the focal point of all complications, and this combination helps us to get good result. And the last example, also patient with diabetic retinopathy. She was administered aflibercept, and then she didn't visit us. It's a very dramatic moment when they stopped visiting us. Of course, we understood that now the situation is very difficult. Some women, men, they have to go abroad and to come back home. So she didn't visit us for a long time, and then she came back with a recurrency. There were a lot of microaneurysms, and we decided to change the therapy for faricimab, and we were satisfied with the result. One of the same face, the picture of angiogram is much better, and we were succeeded to increase visual acuity and to decrease the thickness of retina. Conclusions: faricimab provides us an opportunity to get quick results. Leakage responds very well on the administration of this medication. Safety profile is quite good. There are a lot of studies, and I have no serious, severe side effects in my practice. Thank you very much for your attention.
Thank you, Mykola Mykolaievich. Are there any questions? Yes, please. Mykola Mykolaievich, tell us, please. Is it not better at first to administer anti-VEGF preparation for thinning of retina, and in order to provide that less tissues remain on the epiretinal membrane, and then do perform the vitrectomy when the retina sets? That's a not bad idea, but it requires thorough attention, because first of all it should be thought when the vitrectomy should be performed. You should expect that after some infection this patient's condition will improve definitely, and then your issue will be how to explain to this patient that he still requires surgery. I would add that truly, if this patient sees his macular fovea after several injections, as practice shows that it is completely possible to talk him into vitrectomy, to explain to him that it is still required. But there is another detail, that if you inject not into the vitreous but into the retina, as far as my opinion, I think that it is more effective, but there is a number of researches say that if injection is made in the water, in the liquid, the effect of treatment could be shorter. Yes, this is an issue that has to be dealt with. I've already discussed it in some conferences. Vitreoretinal surgery has rich experience of this practice, but I haven't found any publications dedicated to this question, and I am personally 100% sure that administered in a different way will behave in a really different way. So yes, thank you very much. This was not the anti-vitreal session, so let us continue with our satellite symposium. We can discuss all the other issues later. clinical cases of intravitreal administration of faricimab in neovascular age-related macular degeneration by Kostrin Taras Bogdanovich. Dear colleagues, my clinical cases to present to you with exudative form macular degeneration, age-related type. The primary patient of 69 years old, like Andrei Yaroslavich said, naive patient. He had neovascular degeneration of macula with detachment of pigment epithelium, 0.6 visual acuity. His clinical peculiarities: in OCT, there is detachment of neural epithelium, detachment of pigment epithelium according to fluorescent angiography, as well as subretinal neovascularized membrane visualized in OCT angiography. We decided to administer 4 loaded injections with interval of 4 weeks. As you may see, after the first injection, the patient showed us improvement of visual acuity. The thickness of retina decreased to 274 microns, and the third injection was followed by further improvement of visual acuity. There was decrease of pigment epithelium detachment. The fourth visit brought us further decrease of pigment epithelium detachment. There was still residual detachment of neuroepithelium. According to the schedule, according to what we observed, we could already let this patient go for 8 weeks and further examine him to understand if new injections would be required. After 20 weeks, the patient came back to us with the thickness 172 microns, the liquid almost totally dissolved, but still we decided to perform another injection, and in 12 weeks the liquid was completely gone and the pigment epithelium width completely followed was completely within the norm. I would like also to show you that within 32 weeks we were able to increase visual acuity to 100% and reach the normal level of thickness. No complications of general condition or eye conditions were found. I would like to focus your attention on different researches, different observations, where authors speak about 2 treatment regimes, a reactive one and a proactive one. The proactive one includes fixed administrations and treat and extend regime. Both regimes have their advantages and disadvantages. Speaking about the reactive regime, there is less opportunity of fewer injections, but the number of visits may increase to regular, which would lead additional load for both hospital and physician. Also, it might be harder to prognose further regime for such patient. We would also like to avoid the risk of visual acuity decrease. The proactive regime disadvantages are the fact that there might be more injections required, although the visits might be more planned and there might occur fewer risks. Another issue which we face with a patient is arises during treatment in case if prior treatment had not succeeded and we have to switch to faricimab. I have collected data from the sources which can be split into two tactics. The first one is with load injections. There are authors who administrate 4 preparations. There are authors who use only 3 loaded injections with further transition to other regimes. Another opinion of other authors is that loaded injections are not needed. For today, in literature sources, there is a recommendation made by British physicians who showed the scheme of transition from one anti-aging preparations to faricimab. And here are 2 key points. One is when we control the disease itself. If response to treatment is missing, then we have to consider the issues of the diagnosis itself or the issues with the treatment tactics, and switch to monthly loaded injections. So we see certain changes which are not enough for us to let the patient go for longer periods, for longer interval. Age-related degeneration of macula can be observed for longer period when we see positive results in loaded injections, but within a year the response to such treatment is less and less effective. Besides, we have to consider the period for the response. We cannot constantly keep the patient on one regime, and we always discuss it with the patient if we should increase the interval between the injections. In some cases, the interval makes up 8 weeks, and another option is 10 or 12 weeks. What should we do? How should we should have a look at the response to the disease. First of all is transferred to 4 loaded monthly injections. Sometimes it is recommended to make 3 consecutive injections. And what happens if there is no response to treatment? Then we transfer to 4 loaded monthly injections, or if the interval between the injections is longer, then in this case we continue the treatment according to the same schedule, and later we switch to the regime treat and extend. I'm going to demonstrate to you 2 cases of treatment when we faced certain issues. The first case was a patient with age-related macular degeneration with hidden membrane. The first time she referred to us, we saw cyst-like formations in macula, and we tried brolucizumab and tried to switch to regime over 8 weeks and transferred to faricimab. The retinal thickness was 336 microns. In 4 weeks, it decreased to 20 microns, and in the end, treat and extend regime. We let our patient go for 6 weeks and made 5th injection. 6th injection was performed on the 8th week when the visual acuity already was 1. Thus, we let the patient for 10 weeks, again without considerable worsening in Q10 visit. I should say that for the period of observation of 36 weeks, 7 administrations were performed in total, with the retina thickness 139 microns, and no side effects were observed in this patient. Another case of a woman, 74 years old. It was a more complicated case because we dealt with quite complicated macular degeneration, choriovasculopathy, age-related, which has bad response to any kind of treatment. Visual acuity in this patient was 0.7, and since 2023 we've administered aflibercept, brolucizumab for short-term effect, and we didn't have the opportunity to let this patient go for a longer period. Finally, we switched to faricimab, 4 loaded injections with visual acuity 0.08 and thickness of 320 microns. After 4 administrations of faricimab, the visual acuity raised to 0.1 and the thickness reached 276. The patient was let go for 6 weeks, and a 5th injection was performed on the 6th week. There was no worsening. For 18 weeks in total, we managed to reach visual acuity 0.1 with a thickness of 124. I would like to highlight that faricimab, due to double mechanism of its action, provides for fast resorption of intra and subretinal liquid and provides for noticeable improvement of visual acuity and anatomical indicators. It gives optimal result of treatment in patients who had not undergone anti-VEGF therapy earlier, as well as in patients who are resistant to current anti-VEGF therapy. Thank you very much for your attention. We are going to have our 4th report now, and all the questions and answers are going to be after the break. Now there is a new reporter.
Good day, dear colleagues. Our today's report is dedicated to clinic experiment of faricimab in everyday life and in complicated events. Its molecule is first non-specific body for intravitreal manifestation. It consists of anti-VEGF fragment and angiopoietin 2. Angiopoietin 2 stabilize the vessels, decrease the penetration and inflammation. That is very important in treatment of vascular inflammation, and it inhibits the systemic response and potential of inflammation. Here you can see schematic action of VEGF factor and increased angiopoietin 2. It provokes fibrovascular components at edema and edema pathology of fundus. You can see epithelial foci and different cases. What about clinical cases? On the upper slide, OCT of 62 years old patient with a diabetic retinopathy in proliferative stage, diabetic edema of severe stage. There were 5 injections of aflibercept, visual acuity 5.8, and there is no thickening of retina. There was practically no difference for patient because of non-effect in thickening. We changed to aflibercept, and his spared eye was there was a surgery on his spared eye. His vision was 1.8. On the lower slide, you can see the condition after the first aflibercept injection. It's an increase of vision up to 1. On the left, the condition after the 2 injections, there is an improvement of vision by 0.15, and we can see the thinning of retina. If we have membrane and edema, we should start with the intravitreal injection. While they are effective, we cannot perform surgery. In this patient, after the continuation of intravitreal therapy, we didn't perform surgery. The next clinical case, 63 years old patient, aged macular degeneration on the left eye. On the slide, you can see big detachment of pigment epithelium. This form of disease is associated with the polypoid vasculopathy. In such cases, there can be complications of pigment epithelium rupture and tear. Facilimumab was the first line preparation, and vision, you can see the increase of vision acuity after the 3 injection. It is necessary to perform loading doses, and we have 4 loading doses. In future, it helps us to make longer intervals, because without loading doses, you can get recurrency very quickly. Loading doses helps us to block them and to inhibit this agent. Then, post thrombotic macular edema, it is necessary to perform 3 loading doses and then treat and extend regimen, but we may continue monthly or every 28 days injections up to the full improvement in vision. Anti-VEGF factor and angiopoietin 2 helps us to use treat and extend regimen after the 3rd injection. There is a clinical event of patient of 54 years. You can see the impairment of retina, hemorrhages on retina, cyst and macular edema, visual acuity 0.3. Here you can see dynamics before and after treatment, during the treatment. After 2 loading doses, you can see the decrease of edema from left to right. The edema can decrease even in the first day, because after intravitreal injections the increasement of vision is quite quick. Then the injections were performed once in 4 months. Interesting fact with atezolizumab, the retina is being improved during 3rd and 4th week. The next clinical case, very complicated, age-regulated retinopathy, very low vision. On right eye, there were performed injections in timely manner, and we managed to preserve the vision. There were supportive doses of preparation. She has a problem with her gland, so that is why she has a lot of additional diagnosis. There was a thrombosis of central vein of retina, a lot of hemorrhages that can be associated to the ischemic type of thrombosis. There are episcleral vessels. She visits simultaneously endocrinologist, and she asked us to administer medication with a quick response in order to preserve her vision. We have here post-traumatic macular edema, and there is an increase in improvement in retinal condition. On right scan you can see improvement of vision up to 0.2. Here you can see the same case before and after treatment. Look at the improvement and on the improvement of eye. Here you can see episcleral vessels after endocrinological treatment. Conclusions: faricimab, due to the bilateral mechanism of actions, gives us a possibility to block disease very quickly. It is very effective in treatment of patients that have already got anti-VEGF medications, and in patients with diabetic edema, retinopathy, and edema associated with vein edema. It helps us to use faricimab as the medication of first response, and it is very effective in the repairment of treatment of retina with the complications of edema. It helps us to increase visual acuity, to thin the retina, and to keep long-term results. Thank you very much for your attention. We finish our section, and at the end I want to award our partners, Roche company, our young partners, but we hope that we will have a few fruitful cooperation for many years. The next section, so you can stay here. I can start section if you like. We have no time, please stay, don't leave us.
У нас Будемо працювати практично без перерви. Там, кому
We are going to
необхідні якісь
work
ургентні
without
справи вирішити,
a break.
будь ласка,
So if
а
anyone has
ми
any
будемо
urgent
продовжувати
business,
без
you're welcome to leave
перерви.
and come
Так,
back,
я зараз
please,
хвилиночку.
as soon as possible, because we are going to continue without the break. Yes, we are going probably to wait for some more participants because less than 20 people in the hall, it's like a little depressive for a reporter. So yeah, they're going to think not about what to say, but who to say.